Dr. Kenneth Liegner. Dr. Kenneth Liegner is a very well-known board-certified internist with additional training in pathology and critical care medicine, who has been working in the area of Lyme and tick-borne diseases since 1988. He has published articles based on his observations and in peer-reviewed scientific journals, and has presented poster abstracts and talks at national, international conferences. Obviously, everybody knows, I think he has cared for many, many patients quite seriously ill with chronic and neurological Lyme disease, and has published some very important papers documenting that case material and the progress of these patients. And most recently, he has been publishing on the use of Disulfiram in the treatment of patients with chronic persistent symptoms. So it is our pleasure to welcome Dr. Liegner today to tell us an update on the Disulfiram work.
Thank you very much, Brian. I'm going to, I guess, pull up my PowerPoint.
Mm-hmm.
Okay. So first of all, I'd like to thank Pat Smith and Dr. Fallon for inviting me to talk today. And it's been great to witness this terrific conference and hear all the interesting presentations from everybody so far. So my talk is Disulfiram in the treatment of Lyme and babesiosis, promise and perils. And disclosures, I am an investor in Spira Sciences, Inc., Convicure, and Flightpath Biosciences. None of these entities are presently offering any products or services. However, one or several of them either have in the past or currently have an interest in trying to develop novel formulations of Disulfiram. And I'll be talking about an off-label use of an FDA-approved pharmaceutical agent, meaning Disulfiram. And also, I'd like to say what I'm presenting is strictly an observational report of experience in our practice and not any kind of a formal study or research. Years ago, at one of Willy Bergdorfer's presentations, he showed this slide, and I've had a hankering to get a hold of it ever since. And recently I had occasion to be in touch with Tom Schwann at the Rocky Mountain Laboratory, and he was able to get this for me. So I love this picture of a man and a man-sized tick involved in Greco-Roman wrestling, and called Man Against Nature. But of course, we all are a part of nature as well. If it hadn't been for Kim Lewis, I have a feeling Disulfiram, the paper about Disulfiram would be, lying in some library shelf, and nobody would have ever applied its use in the treatment of Lyme disease. But in the first Lyme Mind conference that was sponsored by the Stephen Alexandra Cohen Foundation at Mount Sinai School of Medicine in October of 16, during Dr. Lewis's keynote speech, towards the end of the speech, he mentioned the work that had been done by doctors Ravi Potaneni and Jayakumar Rajadas at Stanford, in which they had taken thousands of compounds and done high throughput screening to see what kinds of agents had activity against Lyme. And some of them were extremely active that you wouldn't have thought of, like there was one of the cancer chemotherapy agents, but Disulfiram was like way up there near the top. So when he mentioned that, one of my patients had been following Kim Lewis's work for many years and must have gotten wind that Kim had given that talk. And of course, the good thing about those conferences, they were recorded and put out over YouTube, which is how my patient had occasion to view Kim Lewis's work. So my patient, I'll talk about him in just a minute, he brings it to my attention. So I went to the article and read the article, and I didn't really know a whole lot about Disulfiram because it's really used in alcoholism treatment, and it's not really wasn't my field, but I knew that it existed. So I read this article, and then the next thing, my patient says to me, "Hey doc, could I try this stuff?" So by the way, the compound is a triethylthiaram disulfide. and we'll talk about it a little later. It's got quite a complex metabolism. But anyway, this patient was had been followed by me for years, very, very well documented, had been around the block with all kinds of treatments, and including IV before he came to me. And I was able to design a regimen of high dose amoxicillin suitable for central nervous system treatment because he had neurologic features, and Malarone because he had babesiosis, and minocycline. And with that, he was able to be kept pretty well, able to function, not perfect, but most people don't really want to be on these antibiotic agents if they don't have to. And he had made a number of really good faith attempts to try to come off, and he would be okay for a little while, and then his symptoms would come back. It was extremely demoralizing for him. So when he heard about this, he approached me. And I also want to say that my decision to consent to his request, it was informed by my experience with Vicki Logan here, and other patients like her. She's probably arguably one of the world's best documented cases of chronic and neurologic Lyme disease, and sad to what happened to her, but her tissues, she passed away. Her tissues were studied in depth by Jim Goldman at Department of Pathology, Columbia Presbyterian, and Eva Shoppe, and we'll talk a little bit more about that later. So because of that patient's request, I'm going to talk about the first 3 patients in whom disulfiram was applied, but this paper ensued describing my experience with them. And again, I never would have suggested this to my patients. I only agreed because my patient asked me. It didn't seem unreasonable given the limitations of our available antibiotic therapies. And also I want to mention in this article, I felt it was really important because I realized because of reporting these cases, other people might be encouraged to try it. I felt it was very important to fairly exhaustively discuss in this paper the wide range of potential toxicities that this agent can have that have already well documented in the voluminous literature of its use for alcoholism. So that's really important. So this first patient, I told you a little bit about him already. Yeah, he was so demoralized by needing never-ending antibiotics and antiparasitic that he told me he would sometimes feel like jumping off a bridge. So I opted to, I read up about the drug, how it's used and how it's usually used. And it turned out that 500 milligrams per day was sort of the upper limit of the customary dose for treating alcoholism. So I decided to offer him that. And I'm so accustomed to giving people a 3-month supply of antibiotics at a time, my chronic patients, that I gave him a 3-month supply. I gave him an order for periodic surveillance labs. I asked him, he lived at a distance, so it wasn't easy for him to come to see me. So I asked him to send me a note every couple of weeks, let me know how he was doing. He was doing fine. And his labs were great. And then a couple of months later, he called and left a message on my voicemail, canceling his follow-up appointment and declaring, quote, "I'm cured," close quote. And he also mentioned that he had required a hospitalization, but he didn't tell me why. So I was extremely interested to find out what the story was. So I called him up and he told me that he was doing well. And so I said, well, what were you hospitalized for? And it turned out that he had required a psychiatric hospitalization. And then I did a little more reading on the literature, and it turns out that disulfiram, which can affect neurotransmitters and can affect mood, and there have been cases of mood disturbance, psychosis, and whatnot. And I called him back and discussed it with him. And he said to me, he didn't think it was from the disulfiram because he was under tremendous situational stress at the time. But then he says to me, "Hey, doc, even if it was worth it. And don't fail to offer it to other people just because of that," he says to me. So anyway, it turned out we kept in touch with him, and he had remained clinically well almost 4 years, not requiring any antimicrobial therapy, which is like amazing. So after that first case, and this is a tough case, I discussed this experience with a few of my other patients who were also very well characterized, very tough cases, and who required very intensive treatment to remain well. And so a couple of other patients decided that they wished to try disulfiram. So the second case was happened to be a physician. Very, very well documented central nervous system Lyme. He'd had 10 spinal taps. They all showed selective intrathecal antibody synthesis. He also had babesiosis. He required very intensive treatment by his excellent psychiatrist and very intensive antimicrobial treatment to barely keep his head above water. So, again, this being our first opportunity to use the drug, I gave the same kind of a regimen, and he took 500 milligram a day, and it really had a tremendous impact on him. He was really debilitated, practically bedbound. And it just so happened that around 6 weeks, he needed to go to the hospital for some other reason. And he ended up having a syncopal episode with a concussion. Luckily, he didn't have any serious injury. But because of that, not unreasonably, his neurologist suggested that he stop disulfiram, which he did. And I called him a couple of weeks later, and he says to me, "I think your treatment worked." He had dramatic improvement. He didn't require any further antibiotic therapy. His psychiatrist was able to wean him off most of the psych meds. He had even required monthly ketamine infusions because his depression was so severe, and did really well for more than a year until he had a new tick bite. And that's a whole nother story. But anyway, so that also, we're kind of exploring what are the parameters of duration and dosing. And to me, that meant, gee, maybe some people can get away with only 6 weeks, That's sort of my low end of what I've been using. And then the third case was a retired police officer, been under my care for 25 years, very well documented Lyme and babesiosis, had been through all different kinds of courses of oral, IV combinations, high dose treatment for babesiosis. And we did the same thing with him. He had to back off on the dose because he couldn't handle it, but then he gradually built up, was on it for a couple of months, and at that point was dramatically improved. And I turned to my office nurse, Dawn, and we practically pinched ourselves because we just couldn't believe it. 3 out of 3. He turned out about 6 months later to have relapse of symptoms, and we were able to detect the DNA of the Lyme organism in his case, and he was subsequently retreated and responded again. And he's still under my ongoing care and has required a variety of different approaches, including occasional disulfiram. So after those 3 patients, I published my article, which was May of 19. I was encouraged to offer it to additional patients of mine. And over the subsequent 3 years, we treated about 71 patients. Several were lost to follow-up, so we had really only 67 evaluable patients. And we did a retrospective analysis of what our experience was. Again, this was strictly clinical practice, off-label use. It was not a study. And when we analyzed our patients retroactively, we saw that they kind of broke out into a high-dose group that were at 4 milligram per kilogram per day, or maybe a little bit higher, and a low-dose group that was less than that. And when we asked our patients, what's your impression? Did you experience a net benefit from being treated or not? Regardless of whatever problems they had. And maybe they were trying to please me. I don't think so. 92.5% of the patients, when asked, having undergone disulfiram, endorsed that they believe they had a net benefit. And furthermore, of the patients who were in the high dose group, just a few of them would require more than one course. 36.4% of those were able to enjoy what I defined as an enduring remission, meaning remaining clinically well for 6 months or greater without further antibiotic treatment, which, that's to me, from what I've seen, that was pretty impressive. This is the characteristics of the patients. Some of them were treated for as little as 6 weeks, and some were treated for more than 16 months. However, I want to say those who were treated longer were on much, much lower doses than the 500 milligrams a day. So we started in those first 3 patients on 500 milligrams per day. And by the way, each of those gentlemen was 200 pounds or more. But we've used much lower doses as well. And we subsequently adopted a much more individualized dosing strategy, depending on the patient's tolerance and what the objectives of the therapy were for that patient. So as of July 2020, when we submitted our manuscript for the second paper, this 40.3% were still receiving ongoing disulfiram. We have one patient that I share with Bob Bransfield, who's been on low dose disulfiram, 100 milligrams every third or fourth day for more than 2 years, doing extremely well and no toxicity. At the time, well, in the past, I wasn't sure whether the low dose could achieve enduring remission, but we've been in touch with some of our patients, and at least one gentleman who's on extremely low dose for, I don't know, 6 or 9 months, went off, is remaining clinically well. So it seems that for some people, even a low dose approach can be effective. With the high dose approach, there were quite a few side effects, including fatigue. Close to 50% had psychiatric symptoms. Usually they were fairly mild, but we did have a few cases. I had one case where a patient was hypomanic. Her psychotherapist got in touch with me, and we stopped the drug. And fortunately, she, it wasn't too serious. She did not need to be hospitalized. 27% had peripheral neuropathy symptoms. Usually that resolved, although it sometimes would take a while to resolve. And a few had elevated liver enzymes, but they had to be discontinued in 2 patients, but thankfully they fully resolved. In the low dose, much lower incidence of adverse effects. And fortunately, in our patients, we did not experience any catastrophic adverse effects of disulfiram, which have been reported. It's worth mentioning that early in the use of disulfiram for alcoholism, doses in the range of 1 to 3 grams per day were commonly used. So that might explain some of the very serious adverse effects that were reported. Some of our patients were co-infected with babesiosis, some with Babesia microti, and some with Babesia duncani. And all of the patients endorsed improvement with symptoms that they attributed and we believe were due to babesiosis. And 5 out of 15 who were treated also achieved an enduring remission. And then we had patients with Lyme and Bartonellosis, some with Lyme, Bartonellosis, and babesiosis. I have to say, it's been very hard for me to determine whether disulfiram has much impact on Bartonellosis. I'm not sure about that. Let's talk about some of the perils, because there are perils. There's an excellent series of reports out of Vanderbilt. The lead investigator is William Valentine, and those are referenced. Those are cited in the references. But he's demonstrated that disulfiram can produce a non-carbon disulfide dependent schwannopathy in the rat, and this is very real. This is not flaky. This is not subjective. It really can cause damage to the myelin and the peripheral nerves. And this at the top are normal peripheral nerves, and towards the bottom you can see the effects of disulfiram high dose in rats on the sciatic nerve, including damage to the myelin and to the Schwann cells. So one has to be really vigilant and follow the patients carefully. And this can be sometimes not just peripheral neuropathy, but also motor neuropathy. And one of my patients, who I followed very carefully, and even following her carefully, it was hard. It's sometimes hard to see this coming. She started telling me that it felt like she was, wading through cement, and she really had developed some motor weakness. And again, of course, if you see signs of neuropathy, you must stop the drug. And again, fortunately, she recovered completely and is doing well. Also, some of you may or may not be aware that recently Mayo Clinic Proceedings reported a brief report of an unfortunate case with a patient who was being treated for Lyme disease, and who went on to develop irreversible injury to the basal ganglia that resulted in a long ICU stay and ultimately in fatality. And unfortunately, the people from Mayo used that as a basis of a rant against chronic Lyme disease. But this type of outcome had already been reported in the past. in fact, in the literature that I reviewed in my article, it's mentioned. There are potential downsides, and also this patient was being treated by the practitioner with a combination of tinidazole and disulfiram, and that's specifically contraindicated combination. I can only speculate about the mechanisms of action of disulfiram. It has a very complex metabolism. It has impacts on neurotransmitters that might explain why some people have mood elevation while they're on it. It has immune modulating effects. I've speculated about that maybe it has effects on the cell wall, because originally disulfiram was used in the vulcanization of rubber, and rubber is a lipid and protein mix, and so is the cell wall. So I was speculating, well, maybe it affects the characteristics of the cell wall. And also it avidly has high avidity for metal ions that are crucial to beryllium metabolism, like zinc and manganese. And I've also speculated, it's pure speculation, whether the carbon disulfide, which is a metabolic breakdown product of disulfiram and has known antimicrobial actions, whether that possibly it could be one mechanism of action. Eva Shapi has done great work to demonstrate the reality of biofilm formation in Borrelia, both in vitro and in vivo. She had tissue from a Borrelia lymphocytoma from Europe that she studied and was able to demonstrate biofilm. And this is atomic force microscopy of biofilm grown in the laboratory, and it's got a definite architecture to it. It's got pores. Biofilm is created by the microorganisms, and in order for them to survive within the biofilm, they have egress and ingress of CO2 and oxygen in order to support the metabolism. And in that case of Vicki Logan, again, which came to autopsy, Eva studied the tissues using her special methods, and she was able to demonstrate large quantities of biofilm in multiple tissues, heart, kidney, liver, and brain, and also using multiple methods to determine there were Borrelia within these biofilm. And these were not small; these were as much as 300 microns in diameter. The red cells about 5 microns. So this is a study that mentions measurement of carbon disulfide in patients who are receiving disulfiram, alcoholic patients. And this just goes to show that both free and total carbon disulfide are measurable in nanogram per liter amounts and persists after a single dose out to like 3 days after. So again, pure speculation, but just to remind you that oxygen and sulfur are close to one another on the periodic table over in the upper right-hand corner. And in terms of the size, PM is picometers. So carbon dioxide and carbon disulfide are sort of the same order of magnitude. So I'm thinking, well, if carbon dioxide can go in and out of that biofilm, maybe carbon disulfide also can go in and out of the biofilm. And Eva has pointed out to me that organisms residing within biofilm are 1,000-fold resistant to the action of most antibiotics. So again, pure speculation. I've actually asked Jayakumar Rajadas to do some in vitro studies to see whether Borrelia is susceptible to carbon disulfide. Also, as far as its effect on babesiosis, this was strictly clinical on my part, that the air hunger, the night sweats that are often characteristics of babesiosis that seem to dissipate with the disulfiram, but I have no actual data, to demonstrate that. So in conclusion, in our practice, off-label use of disulfiram monotherapy was observed to be a useful agent for the treatment of Lyme disease. Each patient metabolizes disulfiram differently. For practitioners opting to use this agent off-label, patients must be followed closely with an individualized approach. It is crucial to recognize incipient disulfiram toxicity and discontinue the drug. Recommendations as to specific treatment regimens are inappropriate at this time, pending publications of formal, carefully controlled and monitored clinical research trials to determine the relative risk versus benefit and appropriate parameters of dosage and duration of treatment. Thank you for your attention. This is our team. And this is our team socially distanced. And have ample references about this work.
Okay, thank you, Dr. Liegner.
You're very welcome.
I now will introduce again Dr. Brian Fallon.
Thank you, Pat Smith, for all the great work you and the LDA have done. And I had so much work, 21 years. So thank you. Thank you to all the speakers. Thanks for anybody who's still listening. I can't believe you're still here. But I did want to add one thing. I was talking to Dr. Liegner, and he and I agree that it'd be worthwhile just emphasizing very clearly to the listening audience something about disulfiram. As a psychiatrist and as someone who studies disulfiram, I thought it was important to mention. We both thought it. First of all, disulfiram is not recommended for people who have any kind of severe cardiac disease or psychotic history. It's to be used with extreme caution, even in someone who has, or significant caution in someone who has a history of, let's say, diabetes or hypothyroidism, renal disease, or seizure disorders. So you have to be just really careful about using it, if at all, in those cases. And we're very concerned, actually, about liver issues, because it can also, as Dr. Liegner mentioned, it can enhance the risk of liver toxicity. So there's a lot. The other thing about disulfiram, and just as someone who has researched it and studied it, is that alcohol is in our environment everywhere. And you can have disulfiram alcohol interactions just from not knowing it, and they can be quite severe. So I'm just saying this to emphasize the importance of being aware of the risks of disulfiram. And it should not be used in any cavalier fashion. It should only be used under very careful guidance by a physician. As you know, it's approved for the treatment of alcohol dependence, and it's being looked at as a potential benefit for people with a history of Lyme disease for persistent symptoms. But it's really being examined at this time, both for safety as well as for efficacy, as Dr. Liegner recommended in his slide. So thanks so much again to everybody for attending. And I look forward to the conference again next year.